So our next talk is from Ryan Barron from Liverpool. So Ryan is part of the dynamic duo called Racklin. Himself and Declan have worked really hard to create a very thriving program in Liverpool. And Ryan is going to give us an expose into distal pancreatectomies. And I think probably one of the most difficult things for us as HPB robotic surgeons going from level 1 to level 3 is getting through that middle phase where you're really finding your feet. So over to you, Ryan.
Thanks. So my name's Ryan Barron. I'm the clinical lead now for pancreas surgery in Liverpool, having taken over that role from my colleague, Mr. Dunn, who's really got the momentum going on our robotic pancreatic program. So it's made it easier to keep that going. So we're going to focus today on the advantages, pitfalls and considerations of robotic distal pancreatectomy and reflect on our experiences setting up those service. So I'm sure as everybody in this room knows, distal pancreatectomy is a standard surgical procedure for removing benign and malignant pathologies of the body and tail of the pancreas, traditionally performed with open surgery or laparoscopically, but now with the evolution of robotic distal pancreatectomy, there's some unique opportunities available to help develop in this field. We're going to reflect on those throughout the presentation. So in the video, you got myself and Declan Dunn in the middle. And the other great thing about this whole program and the support we've had from Jawad and others through the country and establishing the WhatsApp group has been really the collaboration and support that all units have provided for each other. So we recently ran a course up in Liverpool and we were supported by Tim and by Alicia from Birmingham and the Royal Surrey, and there's been national chat, and it's really a supportive environment to grow robotic programs in. So Liverpool, we started our robotic journey in 2020, and that was when we first had our first case observation visit. We went to see Quintus Molinar over in Utrecht, and that really lit a fire for both Declan and myself that this was real benefit that could be offered and that we'd like to bring back to our patients. There was unfortunately a slight hiatus in getting things going due to the COVID pandemic, and things really then started to ramp up again in 2022 when we got the business case through the New Technologies and Techniques Committee approval, started our simulator and online training, and then started case observation. And then the first case was done in November 2022. So we've had just over 2 years of experience so far. And in that time, we've now done 207 robotic cases. Our practice is entirely pancreas. We don't have the luxury of doing liver surgery as well. And that made it a little difficult on the level 2 cases because we were reliant on only pancreas opportunities for our level 2 cases rather than some of the liver resections. So moving on to some of the advantages that have been highlighted for robotic surgery and how we benefited from those. So two of the key advantages in the literature for robotic pancreatic surgery are the enhanced dexterity and precision. 7 degrees of freedom of the arms really gives you significantly improved maneuverability compared with laparoscopic surgery. And that's really useful for fine dissection around vessels and also avoiding trauma to the pancreas whilst dissecting. You've also got superior visualization with high definition views, 3D and magnification. And what that's meant for us is we've taken much more of our practice into the minimally invasive field. So we're now more comfortable taking on lesions closer to the portosplenic confluence. We'd be happier doing lesions involving other organs. We've done on-block colectomy and gastrectomy on block with distal pancreatectomy. And then for the spleen preserving procedures, there's that extra dissection and the precision defined view you get of the vessels really opens up spleen preserving surgery, particularly the Kimura technique, but also the Warshaw technique. So that's really made distal pancreatectomy, robotic surgery is now our go-to for all real distal pancreatectomy, except a very few cases. Another advantage of robotic surgery that's often not talked about as much is the ergonomic benefits for the surgeon. So having the seated position at the robot with wristed instruments really does reduce fatigue compared with long open operations, particularly if they were done laparoscopically. So that's been great for us. You've got a really comfortable position. You've got greater stability, especially when dissecting around delicate tissue. So you can do things much more fine and precise than you would in a laparoscopic situation. It also results in less physical strain. There's lower physical strain in the procedure, and that will hopefully, in the longer term, lead to enhanced surgeon longevity. And that's really important because in the last 18 months within our unit, 1/3 of our surgeons contributing to our general surgical on-call rota have either had to come off the rota for general surgery or come off for a period of time before returning due to workplace-related conditions, neck and back problems. So I think the ergonomic benefits to surgeons going forward will really be massive benefit later in our careers. So spleen preservation, I'm just going to touch briefly on this because I know it's the topic of other talks from Mike Silver later in the program. So splenic preservation can be done by the Warshaw or the Kimura technique. And as we said, the fine dissection and the enhanced visualization really allows you to dissect out those fine vessels. There's evidence in the literature from the EMIPS paper that surgeons are more likely to take on spleen preserving surgery robotically. The number in the robotic group for attempted splenic preservation was much higher, so they're more likely to attempt that. And not only that, the actual completion of a splenic preserving procedure was significantly higher at 80% in the robotic group compared with 63% in the laparoscopic group. And we've seen that because we didn't really use the Kimura technique as much as we would like previously because it is quite a technically demanding procedure, but we're starting to bring that through. So of the 49 distal pancreatectomies we've done, 16% have been spleen preserving, and that's mainly because the majority have been for a malignant indication. So I would say there's been 2 cases that would have been intentional spleen preserving that have been converted to open. So it's similar to the EMIPS data, that would have been around an 80% success in splenic preservation when it was done with that intent. As has already been alluded to this morning in other presentations, there's good evidence that minimally invasive surgery has good outcomes compared with open surgery in randomized controlled trials, but less evidence for robotic over laparoscopic approaches. So there's meta-analysis data suggesting improvements in spleen preservation, in reduced conversion to open surgery, and to a degree in reduction of post-operative complications with a robotic approach over minimally invasive surgery. As a group of surgeons establishing robotic surgery in the UK, we've established a group called UK ROPS, the UK Robotic Surgery program group, and we've, as Jawad alluded to, we've published a number of papers now, and this is one of the ones that's in press at the moment. So we were looking at the UK-wide experience in left pancreatectomy, and as you can see, the numbers for the start in the UK fit favourably with the literature. Clinically relevant post-operative pancreatic fistula in the first cases was around 1 in 5. Just over 10% Clamidingo grade 3 complications. The post-op transfusion was around 5%. Perioperative transfusion, sorry, was 5%. And mortality of under 1%. We've been fortunate that we've not had a death in our unit. They looked at comparing the outcomes to textbook outcomes. And we divided it into both the competency phase and the proficiency phase for centres, effectively looking at the first 21 cases performed in a centre as the competency phase, and thereafter in the proficiency phase based on the Brescia recommendations on competency. And in the UK series, we didn't really see any significant difference between the initial procedures performed and those later. And that may either be because the learning curve, which is debated, may be longer, and some of the ones in the proficiency phase may have still been in the competency phase. But the series of surgeons in the UK generally had quite extensive laparoscopic experience, with around 70 procedures having been performed laparoscopically before taking on robotic surgery. There's generally shorter length of hospital stay compared with open surgery. It's more difficult to prove a difference between laparoscopic and robotic lengths of stay. In our centre, there is around a 1-day difference, but that wouldn't be statistically significant of robotic over laparoscopic approach. The meta-analysis, the data on length of stay is very heterogeneous across the study groups that they're trying to compare, and there's particularly difference between countries, and that's partly related to complication rates as well as enhanced recovery programs and other support in the community, and just how the whole discharge process runs. So it is difficult to compare, but looks favourable. There is potential for reduction in pancreatic fistula. This is usually based on just a few case studies, cohort studies at the moment, rather than either meta-analysis or randomized controlled trial. Things that may contribute to that is more precise pancreatic transection, improved use of staplers and the closure mechanisms of those, and the potential use for ICG in assessing the pancreatic stump to pick your transection line and analyse it afterwards. But Raj will talk more about that in his talk. So moving on to the pitfalls, we know operative time is generally longer with pancreatic surgery, but looking at a lot of the literature, it's not necessarily...
Ryan, you've got 2 minutes here.
Not necessarily clinically significant. It's often 20 or 40 minutes difference, and there may not be extra case opportunities there. Larger centres such as Z's group have shown that time can approach the time for an open case in super experienced centres. And in the latest meta-analysis, the complex cases involving splenic preservation, the time between robotic and laparoscopic was the same in the more complex cases. There are higher costs in meta-analysis for both operative procedure and for total care is more expensive in the robot group, and that's got to be balanced. So haptic feedback is another limitation, but over time you adapt and that becomes less of a problem with time. And the other issues that's been discussed is the limit access in emergency situation, and having drills, staff training, bringing the whole team on board with you so everybody knows their role in that setting is key to mitigating that. We've only had one conversion to open surgery in our left pancreatectomy group. In the learning curve, it's debated how long that is at the moment, and it's often based on expert consensus rather than other data. We seem to be hopefully progressing through the learning curve now after 50 cases between the two of us. It's clearly steeper, as shown by Adam, I think it was earlier, and shorter than for laparoscopic surgery. In our unit, we've got 2 trained to level 3, and we're bringing on in-house training for, we've had 3 people to level 2 now. So in conclusion, robotic distal pancreatectomy offers significant advantages in precision, visualization and ergonomic benefits, and that could translate to improved outcomes. The challenges include increased operative time and increased cost associated with surgery. In my experience, the lack of haptic feedback hasn't really impaired that process. When centres are picking up these robotic programs, it's going to be based on individualised decisions from institutional expertise, considering tumour factors and patient factors. We do look for the unicorn, especially at the beginning of setting up a programme for the perfect patients with easier disease process before you start to take on the more challenging cases. And as robotic technology continues to advance, and experience grows and the centres lead the way, I do believe robotic distal pancreatectomy will become the preferred minimally invasive approach for a distal pancreatectomy. Thank you.